Okay, good morning, class. Good
Good morning, sir.
Okay. Okay, so this morning we'll continue our discussion on the skeletal system. I'll try and move fast today because we have a lot to cover before the semester ends. So the other time, I think we've finished our discussion on the I've forgotten. I think we did all these things. We finished the appendicular skeleton. I think we did this. We did that. Hello.
Yes.
Hi, sir.
Hi.
Yeah, I think we talk about all these things.
Yes, sir.
Yes, sir.
I think this is what we reach.
Yes, sir. Yes, sir.
Yes, I think we compared the male pelvis and the female bony pelvis. Now, if you see me added anything to it, now that one, don't worry so much. So this one was just showing the pelvic brim. This is the pubic arc in females, and this is the pubic arc in males. Okay. So if you look at in males, just between the index and middle finger, in female, between the thumb and index finger, when you open it up, that gives you the angle. Then I explained the importance of the ischial spine doing pudendal block, the anterior superior iliac spine doing gluteal injection. Okay, so the femur, there isn't much to know about the femur. That's the thigh bone, the longest and strongest bone in the human body. And a large protuberance from the femur is the trochanter. So this is a greater trochanter, lesser trochanter. The neck this is the head and this is the neck. The neck is a common site of what? Fracture. We call this part the linea aspera, also on the posterior aspect for muscle attachment. The distal end, we have the conda. These are the condas. So this part and that's the conda. This is the part that articulates with the patella. So that's the patella heart surface. And I've explained what a conda is and what an epiconda is. So there isn't much to say here. Then of course the tibia and fibula. The tibia is medial, the fibula is lateral. Now, if you look at the posterior surface, remember we saw the conda, and the lateral conda and the medial conda. So those ones will articulate here to form the knee joints. Okay. So this is the articular surface for the lateral conda. This is the articular surface for the medial conda. These are the intercondylar MNS. The tibia, as I said, is medial and is the weight-bearing bone of the leg. Is a weight-bearing bone of the leg. Someone has raised their hands. The person can speak out.
Good morning, sir. The last time.
Okay. Audio. Okay. Please continue.
The last I wanted to ask this question, but the class
Okay, you
ended without me.
ask your question. Yes, you
The
can ask.
iliac crest. When someone have a fracture with the vertebra, sometimes they remove it and add it to the vertebra to make it stable. I don't know how it's going to fix.
They remove the iliac crest. This is the iliac crest. They remove it and do what?
And fix it to the vertebra. I don't know how it's going to fix. I've not been to the theater, but I learned that's what they usually do. If you can help me with it.
They fix the iliac crest to the vertebra.
Yes, please.
When they are doing what? That one I don't know.
Spinal surgery. If the person has fracture of the vertebra involving the spine.
Hello, sir. Can I come in? Can I come in here?
I know that I said that's a common site of biopsy. But okay.
Sir,
The one who wants to help can help.
Sir, we are in the same ward. I'm in the same ward with him. The thing is, when they are doing the surgery, what they do is that they harvest a bone from the iliac crest and fuse it there. It's just like I don't know how to. They harvest from the iliac crest here, then they will now go and fix it there. So let's say it's a C-spine injury. So what they do is that they harvest the bone from the iliac crest, then they will go and fix it there at where they are doing the surgery, where the injury is. They want to stabilize the spine there. So what they do is that they harvest the bone from the iliac crest and fix it there. So that's what he was trying to say.
Okay.
So it's like, hello, say.
Hello, I'm listening, Pa.
It's like the orthopedic distance. If a patient gets some fractures and that fracture, it's the bone crashes and it loses some of the bone at the accident scene or something like that. So before you can join the bones together, sometimes they harvest some of the bone from the iliac crest and they join it. Most of the time, it's very small so that they'll be able to stabilize it before they put in their plate or something like that. And it will heal. It heals after some times. So I think that is what he's talking. It's like skin graft.
Okay. You see, I explained that uh, the what do we call it? We have the compact bone and what the spongy bone. And we said that the spongy bone or the cancerous bone or the trabecular bone, that's where we have the bone what marrow. And when it comes to aspirating what bone marrow, the iliac crest is the commonest what site. Is the commonest what site. So I believe that is why they do that. Otherwise, we have a lot of bone cells there. We have, because remember, and also bone marrow, so blood cells are also what are also there. So it's just to help in the repair of the bones. That is why I believe that they do that. So you are talking about being used as a bone graft, yes, because that's where the bone marrow is. And if you need a bone marrow, that is a common site that they take, apart from sometimes the breastbone that they also use. So within those places, you have a lot of, remember, the outside of the bone is covered by periosteum. The inside of the bone it also has endosteum. And this endosteum has these bone cells, the osteoprogenitor cells, and the osteoblasts. So I believe that those ones are, a small piece is harvested. Remember, let me show you something about this. Let's see whether we can go online. Let me just show you something about the iliac crest and spongy bone. So spongy bone iliac crest. Now, I'm just trying to say that you have a lot of, I'm not getting any diagram, but so you see this one here. If you look at this one, this is the scar. So the compact bone and the compact bone, in between you have a spongy bone. So the spongy bone or the tubercular bone or the cancerous bone. So if you also look at the iliac crest, you also have that kind of compact and the two compact bone. The in between you have a lot of spongy bone. Okay, so they are not showing me anything. But then what I'm saying that here, inside here, so this will be a compact bone, but so deep in between, you have a lot of these spongy bones. So there you have blood, the bone marrow, you have a lot of blood cells, bone cells there. So I believe that is why those bones are a piece is used as a bone graft. Okay. Okay, so hey, let me see what the okay. Okay, so I think we can continue. There isn't much to talk about the rest. So for the tibia and fibula, the important points we just mentioned, I was just looking at the parts. So the tibia is medial and the weight bearing bone, the fibula is lateral. The two are connected by interosseous membrane, just like the radius and ulna. This, of course, the ATTAs, they transmit the forces from the sacroiliac joint as it comes down to the femur and to the thigh bone. It also acts as point of attachment of muscles. Now, the fibula is a slender bone, and it's not a weight-bearing bone. Its importance is the fact that it helps stabilize the ankle joint. The ankle joint. The ankle joint is between the tibia, the fibula, and one of the tarsal bones, the talus. So that's the main function of the tibia, the fibula. Now, the tibia on the anterior surface has this tibia or tuberosity, which acts as attachment for the patellar ligaments. The patellar ligaments. And one important part of the bones that you need to know is the malleolus. Pleura is malleolar. The tibia is medial, so it has the medial malleolus. The fibula is lateral, it has the lateral malleolus. If you look at, so this is a medial malleolus, and this is the lateral malleolus. Okay, so this is showing the surface anatomy. Now for the tarsal bones, there are 7 tarsal bones. The wrist contains 8 carpal bones. I mean, each 8 carpal bones, but the tarsal bones are 7. So there is a calcaneus, then there is a talus. This is between the talus and the cuneiform bone, you have the navicular. Then this is the cuboid. The cuneiform bones, there's a medial, intermediate, and so in anatomical position, this will be lateral, medial, and this is the intermediate. So these are the tarsal bones, the calcaneus, the talus. So the talus will fit here to form the ankle joint. The calcaneus is the heel bone. The calcaneus is the what? Is the heel bone. Okay. Then, of course, you have the metatarsal bones and, of course, the phalanges. Now, this is a mnemonic to help recall the bones of the tarsus. Tall camel need milk in large cups. So, talus, calcaneus, navicular, medial, intermediate, and lateral cuneiform, then the cuboid, bones. If there's anything I want you to remember, I want you to remember that calcaneus, the heel bone, and also the talus, when if you're looking at the ankle joint. So these are the special features of each of the tarsal bones. Each of the tarsal bones. Now, you know, the foot has 3 arches. You see, when you stand upright, of course, the foot is not like this. The part that is not in contact with the ground. This one, everything is in contact with the ground. So this one is what we call flat foot. Flat foot, pes planus, flat foot. So the bones and the ligaments is what help to create these arches. So this is a medial longitudinal arch. And this is the lateral longitudinal arch. And of course, this one here is the transverse arch. So these arches are the ones that helps so that the foot does not get in contact with the ground. And that one is very, very important. That one is very, very important. Because these are the functions. So it supports the body weight in an upright position, and also acts as a shock absorber. Apart from these bones, as I said, there are some ligaments that also will be in place. So those ligaments and the bones, they kind of provide spring when you are you are walking and you are running. Okay, so those are what the arches they do. So you realize that if you have this kind of foot, deformity in the foot, I mean this one here, I learned even in the military, you will not be allowed to join, because the whole architecture of the foot is destroyed. Of course, it can be congenital and it can be acquired. Okay. Now, the medial longitudinal arch, if you look at the bones forming the medial longitudinal arch here, you can talk about this one here, the calcaneus bone here. Then the talus, this is the navicular, then the cuneiform bones, then the first and second and third metatarsal bones. So the calcaneus, the talus, the navicular, the cuneiform bones, and the medial first, second, and third metatarsal bones, they forms the medial longitudinal arch. If you look at the arch, the talus bone, is a keystone of the medial longitudinal arch. This bone here. In other words, the whole of the arch actually rests more on this talus on the talus bone. Then, of course, you have the lateral longitudinal arch, and of course, the transverse arch. And the most important arch is the medial longitudinal arch. Is a medial longitudinal arch. So, in pes planus of flat foot, there is a collapse or loss of the medial longitudinal arch, so that if the sole of the foot will be partially or completely in contact with the ground. Okay. Okay, I think this one just says surface anatomy. So when you're actually standing, as we said, the calcaneus is supposed, the soles will be in contact with the ground. The weight of the body is transmitted through the vertebral column, through the sacroiliac joint, through the femur, and through the tibia. Then it will spread posteriorly to the calcaneus and also anteriorly. So of course, once you raise, you wear heart shape, all the force will be transmitted down here, and that's why you feel so much you feel so much pain. Okay, because the calcaneus that is heavy, that's supposed to receive some of the weight. You rather raise it up. You rather raise it up. Okay. These are deformities. You have this bunion and this hammer too. I don't need to read about this one. Of course, if you wear, usually when you wear tight shoes, those shoes that are like bean shape, then you have this bulging of the metatarsophalangeal joints. Okay, so these are just some deformities. You can look at it. This is also another deformity of the foot. The genu varus and the genu vagus. So this is genu varus, leg. Which one? This is a bow leg, and this is what? The lock nails.
Calyx.
Okay. Beatrice hands is up. I want to know why his hands is up.
Good morning, sir. Thank you. Please, I have a question.
Okay.
There is, I don't know whether it's a myth or misconception, something going around that if you are pregnant, you don't wear high heels. So I want to see the relation of that with our bones and how true it is.
So it just like it's not only when you are heavy, when you are pregnant, definitely, of course, your weight increases because of the baby. And so yeah, and if you're also obese, so we are talking about when you are standing, how the weight of the body is distributed. So I was thinking that if you look at the femur, it's a very strong bone. So when you are standing, all the weight is transmitted to the spine. And you can appreciate why the lumbar vertebrae is very, very, very thick, because that's where your center of gravity is around that area. Then you have these massive hip bones. So there is between the hip bone and the vertebrae, between the vertebrae and the hip bone, there is this sacroiliac joint. So the weight transmitted all through the vertebral column through this joint here. Then it's transmitted to the what? To the femur. Then you have to the tibia. You see we said that the femur is the strongest and the longest bone. Then of course it's also transmitted to the what? The leg. And then they look at the calcaneus, very, very big bone. So it spreads posteriorly here and also anteriorly. So definitely, once you are pregnant, I mean, as I say, you gain a lot of weight. So definitely, if you are wearing what do you call it, these heels, you know that it's not easy walking in those heels, and if you fall, if you fall down, of course, you know what can happen. So it's just some kind of preventive measure. You also have a lot of edema when you are pregnant. So why do you are more or less putting a lot of pressure on your foot, with this edema and this increase in weight. Even when you are not even pregnant, you realize that is not ideal to be wearing high heel because you wear it, then you have a lot of what? You have a lot of pain. So just imagine a pregnant woman going through. So I think that is why they advise to not to do that. You see, even pregnant women are even told not to take what? Pictures. But I think just because the beauty kind of they lose some beauty. That is why they don't take those pictures. Yeah, because of course after delivery you look more beautiful than when you are in your 9th month of what? In your 3rd trimester of pregnancy. So please, it's just some kind of precaution. It's not anything. Okay.
Thank you, sir.
I saw something about what was it? This bow-legged thing. What is it? So I was talking about this. The major knee deformities. So in genu is your knee. So genu values the knee. This one here. So you see, look at the distance between here. So that's why the new angle had outward. But this one is what? Is inward. Okay. Now, what we are saying is that the genu valgus, this one here, is less common. And it usually resolves spontaneously by age 9. So you realize that some children, when they are born, they can have some of these things. We are saying that the valgus, they tend to what? Go away. Please, this one I'm talking about has nothing to do. We are not looking at rickets or anything of that sort. We are not looking at anything of that sort. Now, genu valgus is very common among toddlers and also usually resolved by 18 months. So these ones can resolve on your own. But then if you have this thing beyond a certain age, and of course the cause should be investigated. For example, if you look at this type here, it's common among toddlers and resolved by 18 months. So if it persists or become more severe, then of course you have to be thinking about something else. You have to be thinking about something else. Or maybe you also have to be talking about some metabolic bone disorders like rickets. You have to also be thinking about those things. Yeah, then we have these congenital anomalies of the foot. So you have variations of talipes. I think the commonest one is being the talipes equinovarus. Okay. Of course, these things can also they can also be treated. So, but just to show you some congenital anomalies of the foot. Once again, definitely there will be problem with the ligaments. This is more problems with the ligaments. So they can be surgically corrected. I'm not going to talk about fractures. That one, I checked your book, it's not in it. But then we have close fractures. This one is close. The skin everything is intact. Then this one is an open fracture. Depending on how the bones are broken, we can have transverse fracture, we can have oblique, we can have comminuted fracture. And then, of course, in children, you have what we call the green stick fracture. You see, that's only a part of the bone that is actually what broken. The other part doesn't break. There are so many types of fractures. This one is this classic, like, but we are not going to talk about those ones. Let me see whether, oh, it's not even here. So that is better. We are not going to talk about those ones. This one is impacted by fracture. You see that the part of the femur is what is inside, move into it. Communicated, you see that it breaks into several pieces. Of course, we mentioned something about bone repair. So definitely, once we have this type of fracture, the bone can actually osteoblasts, they'll begin to work, and eventually, after some few months, everything will be repaired. Everything will be repaired. Let's look at some few relations that I want you to know with respect to when there's a fracture. Now let's look at the humerus and nerves. So when there is a fracture of the humerus, there are some nerves that you have to know. So I think we can look at this image here. So this is the humerus. This side is the surgical neck. We said that this is a head and this is the anatomical neck. This one is a surgical neck. And the surgical neck, when there's a fracture, the surgical neck, where we are saying that the axillary nerve may be affected. The axillary nerve is affected. The axillary nerve supply the deltoid muscles, the muscles that you see on the shoulder and the teres minor. So when there's fracture the surgical neck, it can affect the axillary nerve. If you look at the humerus also has a radial groove for the radial nerve. So at the shaft, it can also affect the radial nerve. Then, of course, this is a medial epicondyle. Behind the medial epicondyle, we have in fact, for information, the radial supply all the muscles on the posterior aspect of the arm, the tricep muscle. And the radial nerve supply all the muscles in the posterior aspect of the forearm. Okay, so this is the ulnar nerve passing behind the medial epicondyle. Passing behind the medial epicondyle. So we can talk about supracondylar fracture. So definitely that one was affect the radial nerve. It also affect the ulnar nerve. There's another nerve that is here. They are not showing it. I'm surprised. And that one is a median nerve. So you can see here too, there's a median nerve here. So when there's a fracture here, it can affect the radial nerve, can affect the ulnar nerve, it can affect the median nerve. Here you can see the ulnar nerve passing behind the medial epicondyle. The humerus is nicknamed the funny bone. The humerus is nicknamed what? The funny bone. Why do we call it the funny bone? The funny bone is called the humerus. The funny bone is not the bone, but the ulnar nerve, which one near the humerus and causes a tingling sensation when bumped. I showed you a surface anatomy of the medial epicondyle. Surface anatomy, medial epicondyle. I just want to show you a surface anatomy of the medial epicondyle. Okay, so this is better. So that is the medial epicondyle. So we are saying that just behind the medial epicondyle, there is an ulnar nerve. So when you bump this part, the medial epicondyl, it pinches on the ulnar nerve and gives some kind of a funny sensation. And that is why they nickname the humerus the funny the funny bone. So I've shown you the axillary nerve. At the surgical neck, I've shown you the ulnar nerve passing behind the medial epicondyle. I've shown you the radial nerve and the median nerve. Now let's also look at another nerve, common peroneal nerve. Common peroneal nerve. So this one is nice. This is a very, very nice. So this is a common peroneal nerve. This is a common peroneal nerve. Let me show you the nerve from the back. From the back, please, for your orientation, this is the popliteal fossa. This is the popliteal fossa. This nerve is the sciatic nerve. This nerve is the sciatic nerve. The sciatic nerve is actually two nerves together. There's a tibial nerve and there's a common peroneal nerve. So here it's split into two, the tibia portion, and this is a common peroneal one. So the point that I want to see is that you can see where the common peroneal nerve is passing. It's related to the neck of the fibula. So if there's a fracture of the neck of the fibula, it will also affect the common peroneal nerve. So the common peroneal nerve is related to the neck of the fibula, related to the neck of the fibula, the common peroneal nerve. And to help you appreciate the area that the nerve supplies, the common peroneal nerve supplies it's giving the superficial and the deep branch. It supplies the muscles at the anterior aspect of the leg muscle. You know that in anatomy, the leg is, what do you call it? Between the knee joint and the ankle joint. So there's it. So this is the anterior aspect of the leg. So all the muscles on the anterior aspect of the neck and all the muscles on the lateral aspect of the leg and the muscles in the dorsum of the foot, they are all supplied by the common peroneal nerve. So you can imagine what will happen when you have a fracture at the neck of the fibula. Okay, so it's those important nerves that I wanted you to know. The neck of the fibula, we have the common peroneal nerve. The surgical neck, we have the axillary nerve. The medial epicondyle, we have the ulnar nerve. Then, of course, we have the radial nerve on the lateral side. Then in between, we have the median nerve. Okay, so those, then on the shaft, we have the radial nerve. So that is that. Okay, so we are done with the skeletal system. I wanted to look briefly under I want us to talk about joints. Then we'll be done. We are not going to look at the joints of the body. Just going to do just an introduction. We are not going to look at all the joints of the body. We don't have enough time. So those ones you can read on that.
Say, please, someone's hand is up.
Okay, the person can ask.
Sir, please, I wanted to ask that when a nerve is severed, can it be repaired?
Yeah. When they cut a peripheral nerve, they just suture it and it will repair. Uh, I'm not sure whether I touch on those ones, but I remember when we were looking at when we're looking at what do you call it? The nervous tissue. The nervous tissue. I remember we talk about the nervous tissue. Let me see what I can. The slide is here. Oh, interesting. Yeah. When we're talking about the nervous tissue, I remember teaching you that the Schwann cell, the Schwann cells can form what we call a regeneration tube. The Schwann cells. So I think I explained something here. And the most first point that I mentioned was that in the peripheral nervous system, the peripheral nerves, they have a high capacity for regeneration compared to central nervous system, because the Schwann cells can form a regeneration tube. In the central nervous system, the brain and spinal cord, when there is damage to the neurons, astrocytes will begin to proliferate, and they form a scar. And that scar that they form will prevent regrowth of axons. And the cell that produce the myelin sheath, the oligodendrocyte, they don't have that capacity, that ability to also produce a regeneration tube. So I remember I use this one here, explain to you that when there's an injury here, remember, if you are looking at a nerve, the cell bodies will aggregate somewhere and form a ganglia or the nucleus. And then the axons will form what? A nerve, if you're looking at the peripheral nervous system, and a tract when you're looking at the central nervous system. And I also explained that these nerves, or in this tract, they have connective tissues around it. So you realize that here there's an injury here. The distal part degenerates.
Sir, we can't see your screen, sir.
You can see my screen. Hey, then how am I sharing? Can you see it now?
Yes.
Okay. So I was saying that when I taught this one, I made a point that is how a nerve looks like. This is how a nerve looks like. The individual axons will have what they call it, a connective tissue that we call the neuron. A bundle of it will have a connective tissue that we call perineuron. And the whole will be surrounded by a connective tissue that we call a perneuron. So when then I said that the central nervous system, the brain and spinal cord, the neurons there, they have very limited capacity for regeneration. The reason is that astrocytes, the most abundant glial cells, they proliferate and form a scar. So that regeneration becomes what? Difficult. Then the cell that produces the myelin sheath is called oligodendrocyte. They don't have that ability that the Schwann cells in the peripheral nervous system have. The Schwann cells in the peripheral nervous systems, they release growth factors and also form regeneration tube. Regeneration tube. So if you look at here, I explained that when there's an injury here, the distal part will degenerate. The axon will degenerate. The myelin that have been produced will degenerate. But look at the Schwann cells. They are proliferating and they form a tube that guides the regrowth. So once a surgeon cuts a nerve, the surgeon will have to make sure that just suture the nerve, and regrowth will be possible. But we are saying that ability is limited in the central nervous system. Okay. Now to our discussion on joints. I've already made this point that we are supposed to do all the joints in the body, but there are a lot of things to cover this semester. I think there's cardiovascular system that we haven't talked about. There's a lymphatic system, and there's a respiratory system. So I will leave those ones out for you to look at. But we need to do an introduction. The introduction there, you must have it. So we are going to have introduction. So we know what a joint is. Union between two or more bones. Between two or more bones. The joint structure determines its function and range on what? Motion. And that one is true. So another word for joint is what? Articulation or arthrosis. So arthro has to do with joints. So arthrology, study of joint. Arthritis, inflammation, arthroplasty. So plasty, that means there's a repair going on. Then synthesis, where fluid will have to be what? Will have to be drained. Okay. So when you look at joints, you can classify joints structurally and functionally. Functionally, we have immovable joints, slightly movable joints, and freely movable joints. Immovable joints are also called synarthrosis. Slightly movable are amphiarthrosis, and freely movable are diarthrosis. All synovial joints are diarthrosis. Okay, the types that you are seeing here, we'll look at them, so don't worry. So just know that there's synarthrosis, amphiarthrosis, and diarthrosis. By structure, so by function, we are looking at the amount of movement permitted. So freely movable, slightly movable, then immovable. Then by structure, we are looking at, so we are saying that where two or more bones meet. So where they meet, what is the material that binds the bones together? So you can have a fibrous joint. So at a fibrous joint, we have a fiber connective tissues. A cartilaginous joint, we have a cartilage present. Then a synovial joint, we have a joint capsule. We have a joint capsule. Okay. So these are examples of fibrous joints. So on a fibrous joints, we have suture, syndesmosis, and gomphosis. So here, this is a suture. So let's say this is this is a parietal bone and this is occipital bone. So they are connected by what? A suture. A suture is, if you want to classify it by function, it's immovable joint. If we want to classify it by structure, then it's a fibrous joint. Then we have syndesmosis. Remember, the tibia and the fibula are connected by interosseous membrane. The ulna and radius are also connected by interosseous membrane. So those ones are fibrous tissues connecting the two bones. Then finally, but of course here there will be some small amount of movement. So you realize that syndesmosis is classified as slightly movable joint. Okay. Then between the teeth and neck socket, we'll do the teeth later, second semester. Between the teeth and neck socket, this is also immovable joint. We call it gomphosis. In fact, gomphosis is a special type of syndesmosis. So dental alveolar syndesmosis is also called gomphosis. Okay, so under fibrous joints, these are the types that we have. The fibrous joints, the adjoining bones are united by fibrous connective tissue. So we have suture, syndesmosis, and gomphosis. Gomphosis, we have the periodontal ligament. So these are the periodontal ligaments. connecting the cementum to either the maxilla or the mandible. Then we have cartilaginous joints. The cartilaginous joints, what's connecting the two bones is what? Is the cartilage. We have the cartilage can be hyaline cartilage or it can be a fibrocartilage. So if it's a hyaline cartilage, we call it synchondrosis. And if it's a hyaline fibrocartilage, we call it a symphysis. We call it what? A symphysis. We call it a symphysis. So between the body of the vertebrae, there is an intervertebral disc, which is a fibrocartilage. Between the two pubic bone, there is a pubic symphysis, which is a fibrocartilage. Which is a fibrocartilage. So then between the manubrum, you know that the breastbone is made up of the manubrum, the body, and the xiphoid process. Between the manubrum and the body of the sternum, the manubrosternal joints, is also a fibrocartilage. Then between even the sacrum and the coccyx, between the sacrum and the coccyx, there's also a fibrous joint. But the most important type of fences that I want you to, at least you should remember, is this one, between the body of the vertebrae and between the two pubic bone. Those are symphysis type of joints because the bones are united by a fibrocartilage. A symphysis is also called a secondary cartilaginous joint. Then we can also have a hyaline cartilage uniting the bones. So if it's a hyaline cartilage, then it's a primary cartilaginous joint or a synchondrosis. The joint between the epiphysis and the diaphysis in the growing bone, remember within the growing bone, there's epiphyseal plate. Epiphyseal plate. So here there's diaphysis and epiphysis. So that one too, you can classify it as a primary cartilaginous joint. Then remember the hip bone. We said that it's made up of three bones fused together: the ilium, the ischium, and the pubis. So at the acetabulum, you see them fused together. So this one here is this Y shape thing here is actually a hyaline cartilage. It's a hyaline cartilage. It's a hyaline cartilage. So uniting the three bones together. Then if you look at between the costal cartilage you see, this is the costal cartilage, and this is the manubrum. Here, actually, you can look at two joints that are here, that are there. There's a joint between the costal cartilage and of the first rib and the sternum. And here you are seeing between the costal cartilage and the bone that make up the ribs. So there's another joint here. What do we call the joint here? Let me use a marker here. What do we call the joints? So that one is, let's say, A. Then this one here is what? Is B. So what do we call the joint here? Hello.
Hi.
So what is A and what is B? Hello.
Hi.
There is this sternoclavicular joint.
Hi.
I say,
You are saying is what?
Is this sternoclavicular joint?
Steno what? Which one? A or
Clavicular
B?
joint.
The B.
So the
The
B
B is
is
what?
Sir,
manubrosternal joint.
Steno what?
Manubrosternal or
Sternocostal.
B is
sternoclavicular.
sternocostal. B.
manubrosternal or sternal.
The sternum plus the rib, sternocostal joints. Or say,
And I'm saying that which is I made something like A and B.
understand.
So you tell me A, then you tell me what it is.
So A is sternocostal joint. Sorry, B is sternocostal joint.
Okay. Then
A
A is what? A is what?
The costosternal joint.
Costo what?
clavicular.
Sternoclavicular joint.
This is not a clavicle.
Yeah, hello.
This is still the rib. This is the first rib.
Oh, okay.
Costosternal.
So A is costochondra. Costochondra what? Joint. Costochondra what? Joint. Then B is your stenochondral what? Joints. The sternum. Okay. There's a point that I wanted to make here. And please pay attention. The rib and its costal cartilage here. The joint between the rib and its costal cartilage. This one here. We are saying that it's a costochondral joint. It's a costochondral joint. So those ones are primary what? Cartilaginous what? Joints. I don't have the whole of the sternum. That's why I'm only using this one. But then you remember there will be second rib too. So between the rib and its costal cartilage, all those ones are costochondral joints. Those ones are costochondral joints. So those ones are all primary cartilaginous joint or synchondrosis. And movement doesn't occur there. Just like here too, movement doesn't occur there. Then between the one that I'm showing as B, the sternum and the costal cartilage of the ribs, the first one, the first sternocostal joint is a primary cartilaginous joint. You know, the second rib will attach here. The third rib will attach to the body. Fourth rib, fifth rib, sixth rib will attach to the body. It's only the first one, the first sternocostal joint, that is primary cartilaginous. No movement occurs there. But the second to the seventh sternocostal joint, those ones are synovial joints. Those ones are synovial joints. So that is all that I just want you to note. As I said, we are not doing all the joints of the body. And we are looking at a joint where the bones are united by what? A costal what? Cartilage. And we are saying that if it is a hyaline, then it's a primary cartilaginous joint or synchondrosis. Example of synchondrosis is the epiphyseal growth plate. Then the ribs and its costal cartilage, the costochondral joint. Then the first sternocostal joint, they are all primary cartilaginous joints. They are all primary cartilaginous joints. Now, if you look at here, you will realize that most synchondrosis are temporary and disappear. In other words, if you look at here, the epiphyseal plate will become a epiphyseal line. This one to the cartilage will go. And we have those one that persist into adulthood. Those ones are the first sternocostal joint and the costochondral joint. Okay, so we are done with the fibrous joints. We have done with the cartilaginous joints. Then the last one is a synovial joint. So this is a synovial joint. And with the synovial joint, there is a joint.
Sir, please. This one, I
Yes.
want to ask a question before you move on. Please, why is it that the first joint of the rib is a primary joint, but the other ones are not?
You see, with the primary ones, movement doesn't occur. So you realize that when movement doesn't occur there, let's see whether okay. So if you look at the rib cage, now at the next semester we'll be looking at respiratory system. Now, if you look at the way the ribs moves when you are doing inhalation, so you have something like this. You know that the ribs, they move up and out. So this one here is the first sternocostal joint. Okay. It's a primary cartilaginous joint. The rest here,
yes,
they are all synovial joints. They are plain type of synovial joints. When you then accord, these ones are the costochondral joints. So these are all costochondral joints. You say the movement doesn't occur there. So you realize that when you are breathing in, doing inspiration, we are saying that the ribs will move up and out. You don't want a situation where this one too will be moving. It shouldn't move. I don't know how to explain it further. It's not supposed to move.
Yeah, please, I want to ask.
This
so
one,
when the joint is not moving, that means it's a primary joint? Or it's just applied to the rib cage?
No, when I say primary cartilaginous joints, that means that joint, there's a cartilage. It's primary cartilaginous joint and secondary cartilaginous joints are types of cartilaginous joints. So it's primary when the cartilage connecting the bones is hyaline cartilage. And it's secondary when the bones connecting the cartilage connecting the bones is a fibro cartilage. It's a fibro cartilage. So the primary and secondary, primary means synchondrosis. Secondary is what do you call it? Symphysis. And primary or synchondrosis is a cartilage that's uniting the bones. And symphysis or secondary cartilaginous joint is a fibro cartilage that is uniting the bone. I thought your question was why the first one here, the first sternocostal joint, why that one is a primary cartilaginous joint, but the ones here are not.
Yes.
The ones here, there is a synovial type of joint. You know, synovial joint means that there's a synovial fluid there. There's a joint capsule there, so there's a synovial joint. So it means that this side here, it moves. Primary cartilaginous joint or synchondrosis, movement doesn't occur there. So if you look at immovable joints, it's not only suture that you find there. You also find primary cartilaginous joint or synchondrosis. Movement doesn't occur there. And I'm saying that movement should occur because see the ribs is supposed to move up and out. You don't want a situation where everything what moves up. So this part will have to be stable. The cartilages also have to be stable. It has to be stable. But here there should be movements that should occur there. There should movement that should occur there. And of course, when you are doing CPR, that one too also helps it a lot. Because in CPR, of course, your hand will be placed where? Somewhere here. In the lower part of the what? The body of the sternum. So definitely some movement can occur around here. So that when you're doing what? CPR. So you realize that, and when you are looking at joints and you're looking at what do you call it? Synarthrosis, immovable joints. The one is suture, one is gonphosis, and one is synchondrosis, which is a primary cartilaginous joint. Movement doesn't occur there. But if you are looking at slightly movable joints, you can talk about symphysis, which is secondary cartilaginous joint, where, of course, the intervertebral discs, there's movement, there's slight movements. Then between the pubic bones, there's a slight movement. So symphysis is a slightly movable joint. Syndesmosis, between the radius and ulna, between the tibia and fibula, those interosseous membrane connecting the bones together. So that one is slightly what? Movable. A synovial joint is made up of, you have the two bones connected to what? The two bones. And the ends of the bones will have what we call an articular what? Cartilage. Then there is what we call the joint what? Capsule, or the articular capsule. It's made up of an outer fibrocapsule and an inner synovial membrane. The synovial membrane will produce synovial what? Fluid. The synovial membrane will produce what? Synovial what? Fluid. So the articular capsule is what we also call what? The joint what? Capsule, made of an outer fibrous capsule and an inner synovial membrane, which will produce what? Synovial what? Fluid. We know what the articular cartilage does. It covers the ends of what? The opposing bones. Their job is to reduce friction, more importantly, acts as a shock what? Absorber. The articular cartilage is hyaline. It's hyaline. And I said that hyaline cartilage and fibrocartilage, they undergo degenerative what? Changes. Unlike elastic what? Cartilage, hyaline cartilage and fibrocartilage, they undergo degenerative what? Changes. So you realize that with time, these articular cartilage will what? Which is made up of hyaline will wear out, so that the bones will begin to what? Rub against what? Each other. Not completely, but you see a part of most of the part worn out. So that will give that condition that we are calling osteoarthritis. Okay, so that's what a typical synovial joint will have. Other thing that you can have at the synovial joints, in the new joint, there's something that we call a meniscus. If you ever chewed a cotoje before, then you probably have chewed a meniscus before. Then you have these things that we call beza. This is a beza, this is a beza, this is a beza. It's in front of the patella, so prepatellar beza. So these are bezas. These are bezas. There's another beza here. And what are those bezas? Bezas are synovial fluid-filled sacs. So like this one here, like this one here. They are synovial fluid-filled sac, where ligament, muscles, skin, tendon, or bones rub against each other. Now, you see what has happened here? This one is an inflammation of a what? A beza. This one is the elbow. So there is inflammation of what? The bursa what? There. So that what we call what? Bursitis. We call it bursitis. There is a name that they give to some of them. They have something like a kind of nickname. They have something like house-made bursa, house-made bursitis. Why are they calling it house-made bursitis? Because they knew, and when they knew, what happens? They knew so that they can clean the floor. So the prepatellar bursa, inflammation of the prepatellar bursa is what they call. So this one here is there's a patella. So this is a prepatellar bursa. So inflammation of this bursa is what we call house-made nail. So this one is olecranon bursitis. So the bursa that you find there is what is inflamed. At the new, they even have house-made the pastors too. I think they have another one. You know that the pastors also kneel so that they can pray. So inflammation of these bursas are what we call what? Bursitis. Okay. So it can be due to what? Infection. It can be due to repetitive use of that joint. Okay. Then, in fact, they call this one, I think the elbow, this one is what they nickname the student bursa. The student bursa. Then look at here. These tendons here, the tendon here, they also are surrounded by a bursa, but these ones are elongated bursa. So we call them tendon sheet. We call them tendon sheet. A specialized elongated bursa that wraps around tendons. That wrap around tendons. So that at least those tendons can slide smoothly during movements. So when you have them inflamed, then you have tenosynovitis. Okay. So that is by the way. Now, so I've shown you how a structure of a typical synovial joint will look like. Now, how do we classify synovial joints? Synovial joints are classified based on the shape of the articulating surfaces. Then the type of movement that occur. When someone accidentally loses a finger, does it decrease the size? When someone, let me see, that those born with additional finger, does it increase the bone size of the carpal? Of course, if you look at individually, the size of your carpal bones will definitely not be the same as the sizes of mine. If you look at your femur, if you look at your tibia, the length, the strength of it, those ones will not be the same as mine. So definitely, those ones there, they would definitely going to be what? Going to be different. But then if you are saying that for maybe the same person, maybe the right has 6 fingers, then the left has 5. And you're asking whether their carpal bones, the size of the carpal bones will be different. And then of course that one I would say yes. I would say yes. when someone accidentally loses a finger, does it decrease the size of the carpal bones? Why would it decrease the size of the carpal bone? Okay. So look at this one here. So it's based on the shape of the articulating surface, the type of movement. So there's this one that we know. If you look at here, that's what a plain what joint. So there is a plain type of what synovial joint. There is a hinge type of synovial joint. There is a saddle. There is condylon. There is pivot, and there is a ball and socket what joint. So those ones are based on what the nature of the bones, the articulating surface. So let's look at the popular one that we know of, the ball and socket. So it means that there is a ball and there is a socket. So if you look at the femur, this one is the femur and the acetabulum, the head of the femur and the acetabulum of the hip bone. Then you have the head of the humerus and the glenoid cavity of the scapula. Those ones are ball and socket type of joint. Now, if you look at here, this is between the clavicle and acromion. You see, these are flat surface, flat or curved surface. So that is where the two bones they join. So here is a plain type of joint, because the articular surfaces are flat or slightly curved. So if you look at our second to seventh sternocostal joint, our second to seventh our second to seventh sternocostal joints, they are also plain joints, because the articular surfaces are flat or slightly curved. So they are plain type of joint. Then you have a hinge joint, like the traditional door that have a hinge. So you can, and when you open it, you can open it on one side, you can open it on the other side. So here, a typical example is what you are having here. The joint between the trachea of the humerus and the tracheal notch of the ulna is a hinge type of joint. It's a hinge type of joint. Another example of a hinge joint is the knee. The knee too is a hip, what do you call it? A modified hinge joint. It's a modified hinge joint. It's a modified hinge joint. Then if you look at your interphalangeal joint, they are also a hinge type of joint. Then if you look at the atlantoaxial joint, the joint is, you see, between the odontal process and of the azus and the atlas. So that one is a pivot type of joint. This helps you to say no, the atlanto axial joint. Then this condylar sort of joint, the condylar sort of joint, that one, a typical example will be also between the occipital bone, the occipital condyle, the occipital condyle of the occipital bone, and the first cervical bone, the atlas. So the type of joint there that enables you to note your head is a condylar top of joint. So in a condylar top of joint, you have something like an oval or rounded surface that will fit into what? A cavity. A cavity. So that one is that. So you're supposed to know some of these type of joints. Then finally, this one here, very important. The joint between the carpal bone and the metacarpal is the carpal metacarpal joint. The carpal metacarpal joint. The carpal metacarpal joint. Please, the carpal metacarpal joint. Here, I'm talking about the first one. The first carpal metacarpal joint. It's a saddle sort of joint. It's a saddle, you put it on a honky and you sit on. So it's a saddle shaped head. So look at here. The trapezium is fitting into the what? The first metacarpal bones, like the way you put a saddle and on a donkey and you sit on a what? On a donkey. So here the bone is, the type of joint is based on the nature of the bones what? Articulating with what? With each other. Okay. So the question is that what will be the rest? It's only the first one that is saddle joint. The rest of the second to the fifth metacarpal phalangeal joints are saddle, are plain type of what? Synovial joint. Okay. So under ball and socket, we have the shoulder and the hip bone. Under condylar joint, we have the metacarpal phalangeal joint. At the plain joint, plain type of joint, we have plain type of joints. I mentioned the acromioclavicular joints. I mentioned the between the carpal bone, between the tarsal bones. Then I even mentioned the phalangeal joints. Then the pivot type of joint, we have the atlantoischial joints and the proximal radial ulnar joints. The radial ulnar joints. The radial ulnar joints. And I want to show you how the radial ulnar joints, why we are saying that it's a pivot type of joint. The proximal radial ulnar joints. So you can see it here. This is nice here. You see here, this is the radius and this is the ulnar. So radial ulnar joints. You see the head of the radius is articulating with the ulnar notch of the radius. So, but you see that there's this ligament here. So when it's standing, doing pronation and supination, the head of the radius stands here, rotates within this ulnar ligaments, within the ulnar ligaments. Within this ligaments. Okay. So if you look at the movement that we are calling pronation and supination, if you look at this one here, you realize that you see here, this is supination and this is pronation. You see that the head of the radius we are saying that it's a pivot. The proximal with the ulnar joint is a pivot type of joint. The head moves, rotates. Articulating. We also have the type of movement that they allow. So we have non-asia, we have uni-asia, we have bi-asia, we have multi-what? Asia type of movement. So when we say uni-asia, it means that the movement occurs in what? One plane. So bi what will be two planes. The multi will be what? Several what planes. So multi-asia can also mean polyasia. So if you look at non-asia, within the intertarsal, intercarpal, then the acromioclavicular joints, the type of movement that occurs there is what? Sliding or gliding types of movements. So that one, you can say is non-asia. But if you look at a hinge joint, movement occurs in only one plane. So there's flexion, there's what? Extension. There's flexion, there's what? Extension. If you look at biasia, there's flexion, there's extension, there's abduction, then there's what? Adduction. If you look at multi-asia, you have plenty. You have flexion, extension, abduction, and what? Adduction, rotation, and circumduction. So movement is occurring in so many planes. So if you look at here, in terms of movement, this is what? Flexion. This is flexion. So if look at here, this is the arm, this is the forearm, and this is the elbow. So when you are doing, so there's an angle here. So doing flexion, you are just decreasing the angle. And doing extension, of course, you are increasing the angle. So this is flexion. This is what? Extension. Of course, this is what? Flexion. Then when you are standing, you are what? That is extension. Of course, this is flexion. Then that is what? Extension. Then we have abduction and adduction. So in abduction, you bring the body close to what? To the midline. Then abduction away from the midline. So ADD to the midline, away from a midline, abduction, adduction. So here, close to the midline, adduction, away, abduction. So this one too is what? Adduction, abduction. So that's what it means. Then of course you have dorsiflexion. This is the dorsum. So dorsal flexion. Then if you are a ballet dancer, this is what? Plantar flexion. Then when you move the sole inward, it is what? Inversion. When you move it outward, it is what? Eversion. So this thing that they are calling circumduction is a whole rotation, adduction, abduction, flexion, extension, all those type of movements. Then this is what? Supination. Supine position. You see the palm faces forward. Then this pronation, the palm surface is facing what? Down. The palmar surface is facing down. Then this opposition. Opposition is when you use the thumb to touch the rest of the fingers. So tap the first, second. So that's opposition. Then the opposite is what? It's re, who, see, she. So you have so many type of. So you have elevation, depression, and of course these movements occurs at the what? At the joints. And there are muscles that are responsible for these movements. There are muscles that are responsible for these movements. Okay. There's something that the stability of a joint. The stability of a joint is determined by the shape of the articulating surface, the number and position of the ligaments, and the muscle tone. If a joint is stable, these are the factors. There are some joints. They are stable because of the bones. They are stable because of the muscles. One a typical example is if you look at the shoulder joint. The shoulder joint. The stability of that joint is actually the muscles. It's not the bones. Because the head of the humerus is big. But the cranial cavity is small. So that one doesn't give any stability. The stability is the muscles, the rotator cuff muscles around there. They are the one that actually provide stability. There's some of but if you look at here, you see here, the stability is not the muscles. The stability, the nature of the bones, because the head can fit into the big acetabulum. So stability here, the bones, the nature of the articulating surface provides stability. And also, of course, the ligaments that are located over there. Of course, you know a strain, you know a spring. So when you have this is a muscle. Muscles are connected to bone by tendon. Then bones are connected to bones by ligaments. So a strain has to do with when there's a stretching or tear in the muscle or a tendon. A sprain has to do with when it is a ligament. So you strain a muscle, you sprain a ligament. Okay. And of course, you know the right protocol. Then arthritis, because we are looking at synovial joints. So this is what we said about osteoarthritis. You can see that there's degeneration of the articular cartilage. And when you have this degeneration, you can have this. I've also explained to you what the bone spur is or what an osteophyte is. This is gouty arthritis. So gouty arthritis, you have too much uric acid crystal buildup. In fact, normally affect the big toe. So here, this thing that you are seeing here are deposit of uric acid crystals. Okay, so normally affect the big toes, the ankles, and the knees. Then this one here is a rheumatoid arthritis, which is an autoimmune disease. Your immune system attacks the synovial membrane. So if others are for those ones, you can only manage them. Okay, so this is the gouty arthritis. Okay. So rheumatoid arthritis is the second most common type of arthritis. It affects about 3% of all females and about 1% of all males. Wow. Okay. So they're showing this one here as the rheumatoid arthritis. And I think this one here will be osteoarthritis. So here you can see that the bones are actually making contacts. And I think that's why it's advisable once a while to be moving. Yeah, you got to be moving so that the synovial fluid can circulate and nourish the bones. So we are saying that it's aging is a disease that results as you age. So all that you can do is how you can reduce this one from happening. So of course, exercise can help a lot. I think what I was looking for, I didn't know that it was on this slide. So that one is nice. It's here. Yeah, so I'll show you the axillary radial ulna. Then I'll show you the common peroneal. That's fine. We are not going to talk about all these type of fracture. But then you can look at them. Yeah, to look at them. And I'm not sure whether I gave these ones to you. Okay, but I think we mentioned free chest when we were looking at the ribs. Those ones we touch on that. So I'm not going to look into these things. So if you but you still have them in your slides, so that is fine. You can still look at them. As I said, if I were to look at the individual bones, and then we can talk about them. If you want to look at the individual bones, individual joints, then I would advise that you look at, you go online, you visit with this website. I think that website can help you small, so that you look at those who are bones. The noted anatomies. Noted anatomies. Noted anatomies. You see, if you look at, when I go to that site, then the kind of thing that the information they have there is a lot on the bones. I'm not interested in all those information. It is not this person. So I'll even say it here. If there's any, if a site that I will comment to you when you are learning anatomy, I think I can. It's a lot. It tricks the individual bones too. It traces the individual bones. So in your practical, it is something like you identify this. Now, yes. But of course, if something like this will happen, there will definitely be, what do you call it? If something like this happens, I'll find out how the practical will be conducted. Because if it will be this way, then definitely I'll also have to provide answers so that you can choose the correct answer. So the greater tubercle and the lesser tubercle. So if we were to look at the joints, so that's what we have been looking at. So this is the shoulder joints. The head of the humerus articulating with the glenoid fossa of the scapula. But as I told you, the nature of the articulating bones does not offer stability to the joint, but it's the muscle. So this is the spine of the scapula. This is the medial border of the scapula. The fossa here, the depression of the bone is called a fossa. The muscle here is called supraspinatus. Now below the spine, the fossa here is called infraspinatus. This muscle here is called the teres minor. So this one is inserting there, this is inserting there, that is inserting there. Then there's what I've showed you. Those are what we call the rotator cuff muscle. They call it the sit-what muscle acronym. The sit-what muscles. So it is this muscle that actually offer stability to this joint. Now, if you look at here, you realize that, look at here, this is a medial surface to the lesser tubercle. Then look at here. Oh. Oh. Okay. So the supraspinatus, infraspinatus, teres minor, and the subscapularis. Those are the muscles that we call the rotator cuff muscles. SITS. So the other one is the S. So they provide stability. So you see that there's a stability at the top, there's a stability on the sides, but usually you don't have stability below. So the stability here is low. Inferiorly, the stability is low. So you realize that here there's a lot of dislocation occurs here. And the dislocation is anatomically, we say an inferior heart dislocation. An inferior heart dislocation. So bone say it will move from the socket. So dislocation. So that's how. So you can look at the individual joints over here. I'll try and see whether we can do. I'll try and do whether we can do. We can do muscles. I'll try and see whether we can do muscles. I'll try and see whether we can do muscles. For example, look at here. So this is more or less. This is the reason I didn't want to spend so much time on the astrology. Because when you're looking at the bones, they are parts, and all those parts have an attachment to our muscle. What do you call it? The bicep what? Brachia. The bicep brachia. Those muscles the muscle that you find in the forearm. There are three muscles in the forearm. This one here. So you see that it bicep, that means two heads. So this one, they are showing you where the head is coming from. One head is, the short head is coming from the coracoid plexus. The long head is passing from the supraglenoid process. So I didn't want to say so much about the muscle. So you remember the radial groove? Those things. So delta tuberosity means that deltoid what muscles insect there. So you see that is the same thing I was doing. The ulnar nerve passes behind the medial what epicondyl. So showing you the ulnar nerve where it's passing. So on an X-ray, of course, this will be the medial what epicondyl. So here we are looking at the posterior aspects. So if you're looking at the elbow joint, it is this one that you're looking at. Okay. So you like doing all to the individual bones. That's a lot. That's a lot. Okay. So for me, what I want you to know much, that is all. Now I can use, I actually have some notes on the tissues of the body, the what I call the joints of the body. The joints of the body, joints. I don't have them here. I have joints of the body, joints. So I have joints of the body, notes on all the joints of the body, all the joints of the body. So maybe let me see the one that, yeah. So if you are looking at the joints of the body, these are the ones that are very important. So of course, the shoulder joint, we started with the shoulder joint. We are saying the ball and socket joints. The bones that articulate the head of the humerus and the glenoid fossa of the scapula. There are so many ligaments to know. But the names of the ligaments are actually very easy. You just have to connect the two bones together. For example, this is the coracoid fossa, and these are acromion. So coracoacromial ligaments. So the ligament there, they are very easy. So this one is showing you the muscles there, the so-called rotator cuff muscle. So this is showing the rotator cuff muscles. But I was telling you that a lot of dislocation is what? Inferior. Clinically, they call it anterior dislocation. But anatomically, we call it inferior dislocation. Because clinically, they are looking at the head of the humerus related to the infraglenoid tubercle. The infraglenoid tubercle. Infraglenoid tubercle. So this is the glenoid fossa. The tubercle above is the
Please, your
supraglenoid.
screen, no. We can see your screen still.
Can you see the screen now?
Yes, sir.
You can see the screen.
Yes.
Okay.
Yes, sir.
So that's the shoulder joint. So this is the shoulder joint. And what I was saying, and I keep saying, is that the head of the humerus is big and it fits into a very small glenoid fossa. So the nature of the articulating bone does not offer stability to this joint. Ligaments, yes, you can see plenty of ligaments. Plenty of ligaments. Then you can also look at the muscles. The muscles. And if you look at the muscles, you can look at the muscle this way. These are the muscles, the so-called rotator cuff muscles. Supraspinatus, infraspinatus, teres minor, subscapularis. So this one offer protection, stability to the joint, and the ligament. Then in fact, then I said that when there's this dislocation here, dislocation anatomically, we say there's a downward or inferior dislocation. Downward or inferior dislocation. But clinically, when they are describing glenoid tubercle. So you see that the head has slipped from the fossa and is lying anterior to the infraglenoid tubercle. So this one here is what is an anterior dislocation. So you remember this one I showed you, the axillary nerve damage. The axillary nerve damage. And also so there can be radial nerve damage because it's passing the radial groove. So this one here is the dislocation that you are seeing at the acromioclavicular joints. You see. So the joint between the clavicle and the acromion. This is a plain type of what? Synovium. And honor. And this most of the time when you are talking about it, this is the one that we normally talk about. The trochlea, the whole of this is the conda. This is the trochlea and this is the capitulum. So the trochlea fitting into the trochlea notch is the humero-ulnar joint. Then you know that this capitulum, this one here, and that one is also forming another joint. Then between, you know that the radius, head of the radius will fit into the, what do you call it? Then the one here, this one here. This one, between this one and that one, the head of the radius and this one. That's a what do you call it? Humeroradial joints. Then between the trochlea and the trochlea notch, that's the humero-ulnar. Then between this one here, the radius, head of the radius and the ulnar, the proximal radial-ulnar joints. That's what they also call the superior radial-ulnar joints. So the whole joint here is what we are calling the elbow joint. But most of the time when you are talking about elbow joint, you are talking about this one here. Between the trochlea of the humerus and the trochlea notch of the ulna. This one is the typical hinge joint that we are talking about. When you are saying that the elbow joint is a hinge joint. But the one here, this one, the proximal or the superior with the ulnar joint, this one is a pivot type of joint. Because during pronation, and I'll show you that there's an annular ligament. This is an annular ligament where the head of the radius will be rotating around it. Then we talk about ligaments, but those are the ones I'm saying that I'm not going to talk about those things. Then you talk about bases. I mentioned the olecranon beza. So this one is dislocation. Of course, you can understand why dislocation can happen this way. You can't have any this. Then this one called a carrying angle. When some people are walking, you see the way their forearm will be closer to the body. Condylar fracture will affect. Then this one is when you pull this one, like you are pulling it, the head of the radius will be pulled out from the ulnar ligaments. So there's another hip joint. So these ones, you can read about them individually. For the footballers, this is a part that is very important. Collateral ligaments. So that's the meniscus. So there's a meniscus. Yeah, very nice image here. There's the what do you call it? The bases that you find around the knee joint. Yeah, I think they call this one the terrible or the unhappy triad. Normally happen in contact sports. This side is lateral, this side is medial. So there is a direct force on the lateral aspect here. So the anterior tibial ligament is going to tear, medial meniscus is going to tear, then the medial or the tibial collateral ligament is also going to tear. So 3 ligaments are going to tear. The medial longitudinal ligament, there is a tear because if you look it's not in contact with the lateral meniscus. So when there's a blow here on this side here, it's going to tear the meniscus. It's going to tear the anterior, we are looking at the back. We are going to get the anterior cruciate ligament, which is this one. Then of course, the tibia or medial collateral ligament. The cruciate ligaments are very, very important. The cruciate ligaments are very, very, very important. Okay. There's the cruciate ligament. The cruciate, because they form a cross, the anterior and the posterior form a cross. So we call it the cruciate ligament. The anterior cruciate ligament prevents anterior dislocation of the tibia on the femur. Anterior dislocation of the tibia on the femur. Yes. Anterior the dislocation of the tibia on the femur. So you see the one here. This is the tibia and the femur. So what is preventing this anterior dislocation of the tibia on the femur is the anterior cruciate ligament. So when there is an anterior cruciate here, you see when you move this one forward, it will move forward. But then if there is prevention, it's not able to move that forward, then of course it means that the anterior cruciate ligaments is doing their work. So the one that will do posterior dislocation of the tibia on the fibula, posterior dislocation of the tibia on the femur is the posterior cruciate ligament. So cruciate ligament tear. There's a posterior cruciate ligament tear. So when we talk about the cruciate ligaments, it's all about the movement of the tibia related to the femur. So on the femur. Okay. That is that. Samuel can ask the question that he wants to ask.
Okay, sir, please, good morning.
Good morning.
Sir, please, can, let's say, heavy squatting, those who go to the gym and do squatting with heavy weights, can it cause ACL injury or PCL injury?
When you squat?
Yeah, like you are
when you
squatting with
squat,
heavy, yeah, like heavyweight squatting.
On the cruciate ligament.
Yes, please.
Of course, the important ligament that I've mentioned are those two. And if you look at what those ligaments are doing and what you are talking about, if you are squatting, it's not, unless of course, it depends on how you position your body. Because we are saying that the front one, the front one, the anterior cruciate, this one here, this is the tibia. So what they are saying, it's preventing what? Anterior dislocation of the tibia on the femur. And I'm not sure when you are squatting, those ones are involved. Then when the posterior one, the one at the back, will prevent posterior dislocation of the tibia on the femur.